Ultrasound is a useful adjunct to TTFM for graft patency assessment. In the request trial, 3.4% of the anastomoses were revised, and 65% of these revisions were caused by TTFM or ultrasound. By ultrasound scanning of the anastomosis, you can see if the graft is totally occluded, or only the toe or the heel is occluded, or if the anastomosis is compromised in some way. The anastomosis should also be scanned in both views. A useful technique is to allow blood flow into the graft during imaging. These are all examples of patent anastomoses, all looking a little different. This is an intima flap found close to the anastomosis. And this is a large calcified lesion found just distally to the anastomosis. Here you see a narrowing of the leta that was subsequently revised. Here, an example of a purse string effect narrowing the anastomosis. This is a normal anastomosis in the transverse view. Scanning in transverse view, the conduit and native artery will appear as circular structures, melting together. When you inject cardioplegia, you can see how the anastomosis is filling up. Scanning off pump is easier with a stabilizer. To the right, a graft to an intramural LAD, the same LAD you can see to the left before splitting the myocardial bridge. These next video clips are normal proximal anastomoses in 2D and with color flow mapping. This is a side-to-side anastomosis of an SVG conduit on top of a short axis of the native coronary below. In a situation with narrowing at the toe of the anastomosis, you may observe that the blood flows retrograde into the native coronary and further into septal perforators, like here with a small perforator, or here with a large perforator. In this case, the toe of the anastomosis is occluded and there is only retrograde flow. Now the toe is revised and you can see forward flow. If the conduit and the native vessel are perfectly aligned on top of each other and with a perfect anastomosis, an 8-to-0 pattern appears. This is a case with a lima to an LAD graft where an intima flap was obstructing the flow. As shown here, the flow was only 8 milliliters per minute. The obstructing flap was removed and flow increased to 35 milliliters per minute. To ensure there are no kinks or stretched conduits, it is recommended to check graft flow a final time before chest closure. Thank you for your attention.